talk about the top 5 ones. I have no disclosures. So the first one I want to talk about is the partner trial in low-risk patients. As you guys know, there's been this a lot of clinical trials looking at transcatheter valve replacement with both the balloon expandable valve and the self-expandable valve versus open heart surgery in patients with aortic valve stenosis at different risk levels. So inoperable patients, TAVR versus medical therapy, and then high-risk patients, TAVR versus surgery, and then intermediate risk patients, TAVR versus surgery, and then now we have data on low-risk patients with TAVR versus surgery. So we'll start with the partner trial, which is the balloon expandable valve. And what they did was use their latest iteration of the Edwards SAPIEN valve, the S3, because these valves have evolved over time with improvement in their design and delivery systems, and they're now performing really well. So these are the characteristics of the patients that were randomized, surgery versus transcatheter valve replacement, transfemoral approach, not the transapical or other access sites. So this was a TF, TAVI. Age was about mid-70s, predominantly male. STS risk score less than 4%, which is the definition of low risk, was about 1.9% in both groups. New York Heart Association functional class 3 or 4 present in about 30% of those in TAVR and about 24% in those with SAVR. And the difference here was due to people in the surgical arm dropping out of the study, which is not something that was uncommon in these trials when patients were really hoping for the TAVR and then they get randomized to surgery and then they would kind of drop out. Coronary artery disease, about 30%, and the atrial fibrillation, 20 or so percent. And this was the main outcome. If they looked at the composite endpoint of death, stroke, or hospitalizations, and it favored TAVR over surgery at 12 months. So not only was TAVR not inferior to surgery, but it was found to be better than surgery for this composite endpoint of death, stroke, and hospitalization. So events in TAVR about 8.5% at 12 years, and then in the surgical arm about 15.1%. And this is just showing the individual components of the composite endpoints: death from any cause, favoring TAVR, rehospitalizations over time, favoring TAVR, and then stroke, very low, and also favoring TAVR, both at 30 days and then also 1 year. The functional status and quality of life at 30 days is always better in the TAVR arm than the surgical arm, any trial you look at, just because the recovery is quicker in the group, and this was true also in this trial. New York Heart Association functional class 2, 3, or 4 after TAVR at 30 days, much less than surgery, and then about the same at 1 year, so things sort of started looking the same about 6 months and 1 year out. Except the 6-minute test distance remained sort of higher in the TAVR group at 1 year compared to surgery, but KCCQ, quality of life, living with heart failure, but the same at 1 year, favoring TAVR at 30 days, but the same at 1 year. Now, one of the issues that's been a problem with the TAVR valve is this issue of perivalvular regurgitation, and with the S3 valve, that problem really is not a big deal, at least when it comes to moderate to more perivalvular regurgitation, which was seen at 0.8% versus 0% at 30 days, and then at 0.6% versus 0.5% at 1 year. But there was more prevalent mild perivalvular leak, about almost 30% in the TAVR arm versus 2% in the surgical arm. And then we'll just have to see what happens over time, if this impacts anything in terms of outcome at longer than 1 year. But so in the low risk, TAVR did really well against surgery. The 1 year outcomes look great, and we look forward to more extended follow-up. And I think that the low risk trial people, the plan is to follow them out to 10 years. And so we'll see how the story evolves. Now, along with that, sometime recently, there was a partner trial, 5-year outcomes data on the intermediate risk patients. So these are STS risk scores somewhere between 4% and 8%. The 5-year outcomes of that trial were published not that long ago. And you can see the clinical characteristics of these patients is much different in the intermediate risk compared to the low risk. So the age is higher, about almost 10 years older. There's a higher proportion of females in the intermediate risk. STS risk score is higher, obviously. And then a lot more people in New York Heart Association functional class 3 and 4, more prevalent coronary artery disease, and a higher prevalence of atrial fibrillation. So the higher the risk, the higher the prevalence of atrial fibrillation in these patients. Now, what was interesting about that was out to 5 years, and as you know, the TAVR was not inferior to surgery, so it performed just as well as surgery. And then that sort of relationship was maintained out to 5 years. But what was interesting about this is that the curve seems to kind of favor surgery the further out you go, but this was not statistically significantly different. And so all the way out to 5 years, TAVR performed as well as surgery in these patients, which is good to know because now we have long-term or sort of long-term data, even on the durability of the valves, because there was another question about these valves, how long do they last? The aortic valve areas are still high, both TAVR arm and the surgical arm, and the gradients are very low out to 5 years. Now, as I mentioned before, the issue of moderate or severe perivalvular regurgitation was a problem. The intermediate risk used the older version of the SAPIEN valve, the XT, which was associated with more perivalvular regurgitation. And if you look at 30 days, there's more moderate or severe perivalvular regurgitation in the TAVR arm, and that's true at 2 years, and it's also true at 5 years. Now, they looked at the impact of having moderate or severe perivalvular regurgitation or any degree of perivalvular regurgitation over time. So if you take those patients that had perivalvular regurgitation at 30 days and you looked at the outcomes stratified by presence and degree of perivalvular regurgitation, you saw that the outcomes were worse in those with moderate or severe perivalvular regurgitation. Okay, so this is an important aspect of TAVR. We're seeing it less now, at least with the S3 valve, which is encouraging. Out to 5 years, New York Heart Association functional class, similar in both low and similar in both the TAVR and the surgical arm, as well as the KCCQ, living with heart failure questionnaire. Results of that are the same in the TAVR versus the surgical arm. Now, the other valve in TAVR is the self-expanding valve, which used to be the core valve, which then became the Evolut R, which then became the Evolut Pro valve. So even that valve has gone through several iterations. And they also looked at high risk, intermediate risk, and then now they have the low risk data, which was published around the same time as the PARTNER trial. So this is another trial, Evolut trial in low risk patients with severe aortic valve stenosis, TAVR with self-expanding valve versus surgery. Clinical characteristics similar to the PARTNER low-risk patients, mid-70s, predominantly male, low SCS risk, and then atrial fibrillation in about 15% of the cohorts. Now, this TAVR valve was shown to be not inferior to surgery in this particular trial. It wasn't superior to surgery, it was just not inferior to surgery out to 2 years. So they have outcomes data out to 2 years for this particular trial. And the problem, of course, is they used all their valves. So they used the older versions and the newer versions in the trial. But nonetheless, the achieved aortic valve areas and mean gradients were pretty good. Larger aortic valve areas and lower mean gradients across the valve post TAVR placement compared to surgery, but really good results in both arms. Now, there was a slightly higher incidence of perivalvular regurgitation, looking out to 30 days, about 3.5% in this TAVR cohort versus 0.5%. The other problem with the Medtronic valve is just the higher incidence of pacemaker with that particular valve compared to the SAPIEN valve. So here about 17% versus 6% in surgery, in the surgical arm. In the PARTNER data, the incidence of pacemaker was the same. There was no difference between surgery and TAVR with the SAPIEN valve. Now, this is not a clinical trial, but doing TAVR in the lower risk patients then brings to mind this whole idea of whether you can put in tissue valves in younger patients with severe aortic valve stenosis. And this was a retrospective observational study from Spain looking at surgical mechanical valves versus tissue valves in patients aged 50 to 65 years of age. And as you know, the guidelines right now recommend that you can decide with your patient after decision making between the ages of 50 and 70. You have a choice between putting in a mechanical valve or a tissue valve, because most data, or some data anyway, doesn't show any survival advantage to putting in a mechanical valve in that particular age group. And the same thing was found in this retrospective study. Survival out to 15 years after you put in a mechanical valve or a tissue valve in a matched cohorts, age 55 to 65, so no difference. So there was no survival advantage to putting in a mechanical valve in someone between the ages of 55 to 65. Now, I think, some of us would argue with this, and data, at least from Mayo, seems to show consistently a survival advantage when you put a mechanical valve in, but there's an interest now in putting tissue valves in younger patients to avoid Coumadin. Major bleeding is always more in the mechanical valve versus the biologic valve, and then the reoperation rate is higher in the tissue prosthesis or biologic prosthesis compared to the mechanical prosthesis. But as far as outcomes and survival, no difference was seen in that retrospective observational study. The other issue that comes up when you do aortic valve replacement in younger patients is this issue of bicuspid aortic valves. Are these valves suitable for transcatheter aortic valve replacement? Is it okay to do TAVR in BAV? Despite the fact that there's no FDA approval, people have been doing TAVR in bicuspid valves. And this is an international registry looking at outcomes. In fact, they have outcomes for older valves as well as newer valves. And the reason why we don't have FDA approval, or why we don't like doing TAVR in bicuspid valve, is just because of the anatomy of the bicuspid valve. Very eccentric, asymmetric calcification, and sometimes there's associated aortopathy that needs to be addressed that you can't address with TAVR. And then there's sort of higher incidence of perivalvular regurgitation because the valve is eccentric. And the valves are designed, at least the TAVR valves, to open in a circular manner. And if your bicuspid is like this, then that tends to result in perivalvular regurgitation. But this registry showed that with the newer valves, there was really a very low or zero incidence of perivalvular regurgitation after TAVI, and then higher sort of procedural success with the newer TAVR valves compared to the older ones. And this was in about 300 patients, mean age 77, so not really the young bicuspid valves, but bicuspid valve anatomy, and nonetheless, about 70% of them were New York Heart-associated fractional class 3 to 4. So feasible, doable, people have been doing it. There is a clinical trial, I think, but we don't have data from the clinical trial yet. So the other trial, clinical trial, that is noteworthy is the COAPT trial. So just switching gears now from aortic stenosis to mitral valve regurgitation. And the COAPT trial was basically comparing mitral clip versus guideline-directed medical therapy in patients that had severe mitral valve regurgitation and heart failure, the left ventricular ejection fraction below 50%. These are the clinical characteristics of the patients in the device arm and the medical therapy arm. And the guideline-directed medical therapy included CRT. So if you were a candidate for CRT, then you had to get the CRT, see if your mitral valve regurgitation went away. If it didn't go away and you didn't feel better, then you were randomized to the trial. Okay, so guideline-directed medical therapy includes CRT. So age about 70, predominantly male, again, high STS risk. So these were sort of high-risk surgical patients. The etiology of cardiomyopathy predominantly was ischemic cardiomyopathy and a high prevalence of atrial fibrillation in this particular cohorts. And the mitral clip really did well compared to guideline-directed medical therapy. And this is for rehospitalizations after randomization in the control group versus the device group. So the device group really did much, much better than guideline-directed medical therapy. Death from any cause was also lower in the device group than the control group. And then, the success of putting in the clips was about 98%. And this shows us freedom from device-related complications after the clip. So, the clip was really good in this particular population. And actually now it's FDA approved for refractory heart failure in patients that have severe mitral valve regurgitation and heart failure. The other trial that was published along the same, around the same time as the COAP trial, but that trial was negative. This was the MITRA-FR trial. Again, also looking at, heart failure and MR versus CLIP versus guideline-directed medical therapy. And in that particular group, they found no difference between guideline-directed medical therapy and the CLIP or intervention group, but the two trials are really different. I mean, one of the main differences, in fact, is that in the COAP trial, you had to be treated for your heart failure for at least 3 months. You had to get a CRT if one was indicated. And if you improved during guideline-directed medical therapy, and if you improved with the CRT, then you were basically not enrolled in the trial. So you were kicked out of the trial. So this was really refractory heart failure. As compared to the MITRA-FR trial, where they basically randomized people at the onset of them coming in, you randomized to medicines or the CLIP. So there were differences, I think, also in severity of mitral valve regurgitation. It looked like when you look at the data, maybe that there was a higher degree of mitral valve regurgitation in the COAP trial, with effective regurgitation orifice of about 41 in that trial compared to 31 in the other trial. There were differences in left ventricular end diastolic dimensions, where in the I think the COAP trial that was smaller, LVEDD was smaller than in another trial. And then also differences in number of device clips that were put in. In the mitral clip, the median was like 1.7 clips. So they were really generous about putting in a lot of clips to treat the mitral valve regurgitation, as well as differences in duration of follow-up, and maybe with longer follow-up, which for the MITRA-FR, the follow-up was for 1 year, whereas for the CLIP it was longer, that maybe we'll see different outcomes after that. But really, I think the COAP trial established mitral clip as a good alternative to refractory heart failure in patients with a low EF and severe mitral valve regurgitation, and now it's FDA approved, despite the fact that the other trial was negative. Sildenafil for improving outcomes after valvular correction versus placebo. As you know, some of these patients have really bad pulmonary hypertension as a result of their left-sided valvular heart disease. And the pulmonary hypertension may persist after you correct a valvular heart disease. And this trial basically looked at, can you use sildenafil to treat the pulmonary hypertension in those particular patients? And the answer is don't do it, okay? Just do not do it. Worse outcomes in the sildenafil arm compared to placebo. And then there was a nice editorial along with this trial, basically discussing why you can't use sildenafil in that particular population, that there's a difference between pulmonary arterial hypertension as well as pulmonary hypertension from left-sided heart disease, and then sildenafil is good for this, but not good for that, which is why these patients had worse outcomes. And then with that, I will stop, and thank you.